Now I would like to request our respected chairpersons, Dr. Ajay Kaduskar sir and Dr. Faraz Farishta sir, to please come on the stage. I invite Dr. Ravikant, Professor and Head of Medicine at AIIMS Rishikesh. Dr. Kant will speak on complement modulation and immunometabolism, the next frontier beyond lipid and glucose. Please welcome Dr. Ravikant, sir.
Thank you so very much for inviting me to this CardIPCon. The presentation is not there. So I think my previous speaker, Dr. Suri, has very elaboratively told about CKM syndrome, which was basically hovering around predicting the CKM and how to treat it very precisely and taking into consideration the precision nutrition. So my job is to, acquaint you with how the CKM syndrome is basically working across the organs. And I shall be going through a very simplistic approach. I think I shall go through some case-based scenarios. There is some problem with the IT. I think it's not present on the screen. It should have been. So my dear friends, to just introduce the topic, how I am going to discuss in my talk is, despite all the odds, risk stratification, be it cardiovascular, maybe kidney, maybe liver, or maybe any other organ per se. So far as the metabolism is concerned, we know the LDL targets less than 70 is very good for you. We know that the HbA1c target less than 6.5 or 7% is very good for you. We know that BMI less than 25 is very good for you. We know that SGOTPT should be somewhere around 25 to 30. We know everything. We are achieving everything, but we are not, able to curb the menace of cardiovascular mortality, number one. Number two, measly. Number three, the cirrhosis. And number four is basically the diabetes-related deaths. So they are basically unmet need to, see beyond these risk factors, which are traditional in nature. So, for example, obesity is one. Say, for example, diabetes is number two, HbA1c number three, LDL target number four. So I think there is a much larger need to see what is happening. And I tell you, despite correcting all the risk factors, we are able to tackle only 30% of the disease burden. Only 30%. Whatever technology we use. So there is approximately 60 to 70%, cardiovascular death, obesity, or maybe you can stop it. I think I can talk like this. I won't require my presentation. It should have been there by this time. So 60% of the 60 or 70% of the disease burden remains there despite correcting all the odds. Say, for example, HbA1c you maintain less than 6.5%. So where from this 70% morbidity and mortality is coming? When we have corrected everything, we have corrected BMI, we have corrected HbA1c, we have corrected the LDL targets, we have corrected the n number of risk factors. 70% morbidity and mortality is still there. So my dear friends, the mortality and morbidity is coming from the complement activation. We are all talking about the inflammation, but we are not using in clinical practice why this inflammation is there and who is the drivers or primary drivers of this inflammation per se. So the larger need of looking beyond the risk factor is the complements. So introduce the complement. We all know from our UG classes that there is a classical pathway, there is alternative pathway, and there is lecithin pathway. So this complement is quite important from microbial point of view because alternative pathway takes care of the some risk factors, whereas classical pathway is primarily meant for bacterial killing by making MSC, that is membrane attack complexes. So if somehow we can modulate the complement activation and by preserving the microbial killing and focus targeting the alternative pathway, we will be in a position to stop the mortality and morbidity to a larger extent. So if we talk about the complement activation, there are measures by which you can measure the complement activation. And as per se, we are for a pretty long time discussing about the role of HSCRP in cardiovascular morbidity and mortality. Is it open now? Yes. Thank you so very much, although it is too late. So, dear friends, this is somewhat I was talking to you a few minutes back. So there are certain case scenarios. I will come to the first case scenario of 60 years gentleman who had type 2 diabetes, hypertension, dyslipidemia, recurrent episode of accidental chest pain. He is maintained well within, LDL targets less than 55, but he continues to have positive exercise stress and is basically subjected to angiography, which shows a progressive multivessel coronary disease. What the question is, when we have controlled the risk factor, why is he progressing? There is an example of 56-year gentleman with 15 years history of diabetes and progressive lower limb edema and for the urine. He is definitely having, kidney disease from diabetes. His HbA1c is well controlled. He is having persistent albuminuria, declining eGFR. Then when we have controlled this factor, why albuminuria? Then we have another gentleman of 54 years, acute ST elevated MI. He was subjected to primary PCA well in time and perfusion was, successfully achieved. But he still have significant myocardial injury, left ventricular remodeling. What mechanisms contribute to ongoing myocardial damage despite successful reperfusion? And again, this is a lady who is 48 years old, central obese, hypertension, dyslipidemia. She is abiding to all lifestyle modifications religiously. And lipids and blood pressure is well controlled. And she reports good adherence to diet, exercise. But she again has increasing waist circumference, weight gain, and canthus nigricans, frank features of insulin resistance. Lab evaluation says the blood sugar is rising from 98 to 118. My question is, why does metabolic dysfunction progress despite optimal control of traditional cardiometabolic risk factors? So, dear friends, I'll just have an hypothetical situation. That is illusion. Illusion is created by these targets, recommendations. So, for example, maintaining LDL less than 70, HbA1c less than 6.5, blood pressure 130 by 90, and reperfusion achieved is just an illusion. It keeps you under comfort zone and keeps you progressing forward as a clinician. But the reality is there is a hidden systematic deterioration so far as disease progression is concerned, stenosis as well as renal decline of GFR, adverse remodeling, and insulin resistance. When optimal is no more enough, this is no more enough for us to meet the targets. What drives progression when the guidelines have already been met? It is the complement activation. So could complement activation in immunometabolic pathway be the missing link between metabolic disease and cardiovascular injury? The answer is yes. So we need to think about beyond the traditional targets. The status quo says when you have achieved the lipid levels, say for example less than 70 LDL, glycemic control by metformin, SGLT2 inhibitor, GLP-1 RA. But the flaw is 70% residual disease is still there. You can't control it. You can't control the patient going to renal failure, heart failure, and many more. I shall delve into what exactly is happening to these 70% residual risk patients. Complement system is basically a highly complex innate immune defense mechanism. It consists of more than 50 proteins regularly talking to each other. Principally, this is alternative pathway, which is basically driven by C3 and classical pathway and lecithin pathway. This is which I was talking a while ago. So C3 and C5, when they are activated, they forms the complexes. So they are membranatic complexes, and there is amplification loop. This is more of a biochemistry, so I won't go into the details. But they are the primary driver of the cardiometabolic impacts across the CKM syndrome. So principally, if we talk about C3, this is upregulated in type 2 diabetes mellitus, almost 40% higher in metabolic syndrome, and leads to new onset type 2 diabetes, even in persons who do not have a strong family history of diabetes. Nowadays, you will be coming across persons, per se, they do not have any family history, but still they have type 2 diabetes coming in picture. When we say that type C3A, this is basically adipose immune activation. That we say this adipose is not a silent fat, it is active, metabolically active. If we call C5A is a potent pro-inflammatory mediator that drives insulin resistance. And the most important of them is C4 and factor D, that is called adipsin. I will be dealing much in greater detail about adipsin, that is CFD. It correlates well with insulin resistance, dyslipidemia, and central obesity. So CFD is the core of the metabolic dysregulation so far as complement activation is concerned. So what exactly is CFD is, which is a metabolic regulator. CFD is the bridging link between the immune system and the metabolic system. How does it work? At one end, that is the serine protease, the fat cells are there. At the other end, macrophages are there. So adipsin is primarily secreted by adipose tissues and macrophages together. It says that this is the connecting link between them. It's a key metabolic regulator binding the immune system and metabolic dysfunction. So it has a dual role. The CFD at one end is basically metabolic protector. It works as a metabolic protector. At the other end, it leads to inflammatory instigator. That is the reason why we say hypertension, diabetes, metabolic syndrome is a condition of low-lying inflammatory condition. So we need to curb it. We need to, close the loop very tightly. So as a adipokine, CFD provides vital metabolic protection by increasing the beta cell survival and increasing the insulin release from the pancreas. It increases adipocyte differentiation also for more and more fat conservation. It enhances lipid accumulation. In the clinical parlance, due to these metabolic regulatory functions, CFD acts as a protective factor in the context of diabetes and diabetic cardiomyopathy. So mean it, if your HSCRP is high at the beginning of a patient who is suffering from CAD, you can predict that he is going to have cardiac failure in future to come. So this is one of the predictor. So as a complement factor, CFD triggers low-grade inflammation. How? CFD binds to the complement cascade activation pathways, protects cells from acute infection. It induces low-grade inflammation, that is LGI, in cardiovascular disease. If you look at the atherosclerotic plaque and measure the CFD, you will find a direct correlation. The atheroma, the burden of atheroma and the CFD, they are going hand in hand within the atheroma itself and the blood also. So it says that there is a direct correlation between these two entities. So then complement myocardial infarction, if you look, MI triggers immediate damage complement activation. Whatever amount of perfusion you achieve within 30 minutes, even then this injury is going to happen because the pathway is already activated. It cannot be stopped now. So these patients will have heart failure, they will have remodeling and whatnot, despite offering everything. Say for example, time D0, acute MI, immediate phase is activated, detected in the ischemic myocardium, and then there is a damage phase by C5A and membrane attack complex that leads to further cardiovascular damage by CFD. So two distinct systems merge into a unified biological discipline. That is, at one end you have immune signaling, at the other end you have metabolic pathways, and immunometabolism is lying somewhere in between. So I shall be talking about what immune metabolism exactly is. Immune metabolism refers to direct interaction between immune signaling and metabolic pathway. Somehow, if we preserve the complement for the microbial protection or killing and reserve for the metabolic pathway to remain activated, immune cell activation relies entirely on fundamental metabolic programming. This is very important. Even immune cells require metabolic pathways. They require glucose, they require fat, they require protein. So somehow if we tweak these, the fundamental metabolic pathways, we can reprogram the immune cells also. How? Let us see. So we have two types of system, M1 macrophage and M2 macrophage. M1 macrophage is pro-inflammatory that relies solely on glucose. M1 relies on glucose, whereas M2 pathway relies on oxidative phosphorylation. So somehow if we switch this memory from glucose to non-glucose, this complement activation can be taken care to a larger extent. Metabolic substrate availability like glucose, fatty acid, amino acid directly reshapes the immune cell's phenotype and overall inflammatory output. So if somehow we transform this M2 response to M1 response, the metabolic reprogramming can happen. This damage can be stopped to a larger extent. So the activation and impact of the cascade, say for example, once the M1 macrophage is activated, it leads to TNF alpha, and TNF alpha once activated, it leads to switching of M2 to M1. So entire metabolism switch to M1, that is glucose. So impaired glucose uptake is there. There is disrupted mitochondrial oxidative phosphorylation. The more the oxidative phosphorylation is disrupted, more is the inflammation and more is the damage. In the clinical consequence, reduced cardiac energy efficiency leading to progressive cardiac dysfunction and heart failure. So this exactly is happening. After MI, the patient's substrate is shifting from fatty acid to glucose, which is further damaging the heart. So the spectrum of cardiac energy failure, if you look at the fatty acid oxidation, which is a dynamic and adaptive, if somehow it is moving to glycolysis, which is rigid and locked, nothing can be done. Heart will behave like not an autonomous organ anymore. It is part and parcel of the metabolic, diabetes and many more risk factors. If the heart is basically utilizing fatty acids, it is optimal and efficient, and ATP production is high. So beat to beat variation, more energy will be provided by fatty acid, not by glycolysis. Somehow post MI, post heart failure, or for any reason, the heart gets an insult, the metabolic is shifting from fatty acid to glucose, which is very detrimental to the heart. So neutrophilic metabolic adaptations are basically relying on the intracellular glycogen reserve. If somehow the intracellular glycogen reserve is low, this automatically is going to shift towards M2 response from M1. So there is rapid immune activation. This allows neutrophils to function in hypoxic environment, respond rapidly during acute inflammation, and neutrophil extracellular traps. These are the proteins which are secreted by neutrophils immediately under circumstances of stress. So netosis cascade leads, there are 4 steps. Step 1, glycolysis dependent activation. Then step 2, expulsion of NETs. Step 3, plaque instability and thrombosis and acute myocardial infarction. Somehow if this pathway is activated, even your PCI cannot help. Even the thrombolysis, once they are thrombolized, can go to microcirculation, can further damage. So NET formation is strictly dependent on glycolysis, creating a direct fatal link between immune cell metabolism and cardiovascular pathology. So this is basically failing cardiomyocyte, activated neutrophils, activated M1 macrophages, metabolic inflexibility and glycolytic reliance. Targeting this metabolic reprogramming is the future of cardiovascular therapy. And the future lies not in interventions. Cardiac intervention, I must say. This is more therapeutic, more optimistic for the clinician and physicians. Complement activation and metabolic dysfunction drive a vicious inflammatory cycle. Metabolic dysfunction lead to complement activation, which lead to cellular metabolic alteration and worsening metabolism. This is a vicious cycle. This keeps on going. You have to break it somewhere. So conventional therapies fail to address the underlying inflammation driven by complement activation, immune metabolism. Standard treatment like ACE inhibitor, ARB, SGLT2 and GLP-1RA can target glucose metabolic pathways, hemodynamic pathways, but there is unaddressed blind spot for the complement driven inflammatory path. We can't do anything to this. So let us see what can be offered. See, if we go for a C5 blockade, yes, memory attack complex can be spared, so further damage can be stopped. So inhibition of complement factor D, if you selectively block this CFD, then classical pathway and lectin pathway will be functioning, and this way you can be, you're taking care of the microbes, but the inflammatory pathway will stop. So clinical advantage will be selective preserves the classical lectin pathway for better understanding of the opsonization. So we have few active agents like lampalizumab, which is an intravenous molecule, anti-factor D monoclonal antibody, and we have oral preparation like danicopan, which is an oral factor D inhibitor. So they have been tried, and enfloctin receptor inhibitor, if you do, there are multiple benefits by reducing albuminuria and preserved podocyte, improved mitochondrial dysfunction, So there are many benefits of endotoxin blockage. So immunometabolic pathway blockage is a three-pillar approach. It downregulates glycolysis, enhancing fatty acid oxidation, and restoring mitochondrial function, and focusing by improving cardiac energy efficiency. So reprogramming immune cell metabolism shifts the phenotype from inflammatory to protective, targeting glycolysis. We have 2-deoxy-D-glucose that inhibits glycolysis, directly reducing M1 macrophage activation. We have PPAR gamma and delta agonist. We have coenzyme Q10, which is mitochondrial function enhancer. So this is a cartoon that says that glycolytic pathway can be blocked by 2DG, PPAR gamma delta agonist, and coenzyme Q10 can activate the mitochondria. So this simultaneous modulation of glycolysis, fatty acid oxidation, oxidative stress fundamentally transforms the cell from an engine of inflammation to engine of repair. So you can think of, your organ can be repaired. This dual pathway strategy is inflammatory pathway will be blocked by drug A, that is C5A blockade. Metabolic pathway will be blocked by drug B, so for example SGLT2 inhibitor or GLP-1RA, and that can lead to cardiometabolic stabilization. So the preclinical models demonstrate multiplicative, not additive, my dear friends. They are not 1 plus 1, 2. It is 1 plus 1 is 11. So they have shown preclinical demonstrate a multiplicative effect of, enhanced efficacy of lipid lowering therapies and improves response to glucose lowering drugs by complement inhibition simply, either by limpalizumab or danokipan. So immune metabolic targeting offers a critical therapeutic frontier for the global CKM epidemic. This is a personalized profiling, combination therapy, deploying complement inhibitors plus SGLT2 inhibitors plus GLP-1RA together, but complement inhibition must be there. CKM eradication addressing the residual risk blind spot to a certain extent, maybe not 70 exactly, maybe 30, 40, 50%, we can add added benefit to our patient with diabetes, obesity, and CKM syndrome. India's rapidly growing cardiometabolic epidemic demands innovation beyond glucose strategies. Component modulation is that paradigm shift. So clinical translation challenges are timing, when to initiate, specificity, what should be given, which pathways to be blocked, biomarkers, for example, standardized for C3A, C5A, and MACE are required for patient selection and monitoring, and cost is exactly a big barrier. The cost is approximately 2 to 5 lakhs per month if you go for the complement inhibition. So the future vision is integrating precision medicine by precision complement inhibition by GLP-1 receptor agonist, SGLT2 inhibitors, and this will be an integrated treatment model for absolute risk profiling for a better management of patients. So immunometabolic and complement targeting represents a new paradigm in cardiometabolic therapy. So the key takeaway from my presentation is this cardiometabolic disease involves complex interactions between metabolism and immunity. We need to take care of it. Complement activation in immunometabolic pathways plays a central role in inflammation and tissue injury. Immunometabolic reprogramming and complement inhibition offers novel therapeutic opportunities, and future therapies may integrate metabolic, immune, and complement targeted approaches. These are my references. With this, dear friends, I thank you all very much and also invite you to Missouri for the research and innovation in cardiodiabetes and metabolic disorder. Thank you so much.
Excellent lecture. We know the targets, we have the tools, but what is missing you have very well highlighted, and you have also shown us the future about how we can integrate it to have a positive effect on the CKM epidemic that we are facing. Once again, I congratulate you for that excellent lecture. Any questions from the audience? Yeah. Yeah, please, sir.
Sir, a long time before I met you in the chronomedicine conference in Rishikesh.
Yeah, exactly.
Yes. So it's an excellent lecture, but one thing I just want to ask you, that it's a state of, our gut is a state of continuous inflammation.
Yeah, exactly.
So what would be the future prospect of treating or rather changing the gut dysbiosis? Would it be helpful? Because it's a process of continuous inflammation which can, from the womb to from the very onset of our life, the gut microbiota is exposed to so many environmental factors, which can ultimately trigger the inflammatory cascade. So, would it be in the future, particularly since you are in Rishikesh, that's why I'm asking you whether we should be thinking, particularly regarding the Indian dietary patterns, whether the dietary patterns would be helpful in formulation of any this kind of behavioral changes to mitigate to cut down the inflammation.
I fully agree. I think gut is a very potent organ for inflammatory conditions. And mind it, the nutrients could be a trigger. Nutrients could be a trigger. I mean, you need to go beyond the clinical aspect of patient to, going into the depth of the symptoms of the patient. Say, for example, Indians do not tolerate 70%. In our lab, we have seen that there is a lot of, fructose intolerance. There is a lot of lactose intolerance. But despite these facts, we are every day consuming it. So we are basically triggering our immune response towards M1.
Yes, that's right.
And dyspepsia is not resolving because you are giving every other drug, not stopping the milk. Just simply stopping the milk, you can take care of the inflammation, irritation to the gut. So inflammation anywhere in the body, they will be replicated either M1 response or M2 response. Anywhere, even if you look at the cardiac risk factor, dental caries was one of the risk factors because it is leading to inflammatory condition. So you need to bring down the inflammation to a larger extent. Not exactly is the gut. So you need to be very careful about the diet. What are the potential pro-inflammatory diet? And there is a profile of bacteria that favors inflammatory, and there is a profile of bacteria which is different in vegetarian and non-vegetarian. I am not absolutely dogmatic for vegetarian, non-vegetarian, but your gut profile must match towards M2 response, not towards M1 response.
And one more thing, if the patient is already on one kind of DMRD for other reasons, like rheumatoid arthritis, collagen vascular disease, whatever, are they being protected?
Yeah. So if you look at the drug which is used in rheumatoid arthritis, yeah. So they are having less chances of number one diabetes, type 2 diabetes, and number 2 coronary disease also.
Sir, excellent presentation.
Thank you.
So you have given a new thoughts of the complement for the progressions of the chronic diseases. So if my understanding is right, complement it is secreted from the macrophages and also from
adipocytes. Adipocytes.
Yeah, adipocytes. So do there any changes in the formations of the fat or excess obesity or depositions of fat in the ectopic sites? It is associated with this increased activation of complement system?
Yeah.
Or how do this mechanism activated? Is it activated in the normal subjects, or there are certain changes in the parameters, like in CKM syndrome? The first thing is that excess or the obesity.
Yeah.
Or
so I tell you very frankly. So recently we have concluded certain research. Even diabetics who are diabetics absolutely asymptomatic. They are recently diagnosed diabetic. We measured anti-proBNP in those diabetic patients who have no symptoms, and remarkably they are elevated. So they have started heart failure. Recently diagnosed, first visit, the thesis has rightly just now concluded. They have high level of anti-proBNP. So they are at the baseline, it increased. So if we remember the metabolic memory, so diabetes starts almost 10 years after the reprogramming of the cell has happened. So damage is already there. We need to identify it, and any tissue in the body is not a silent tissue. Like the bone, even we are doctors, we say that this is inactive. No, it's not inactive. Similarly is the fatty tissue, adipose. Anywhere adipose tissue is not silent. It is active all the time. So once this is active, this is basically leading towards a pro-inflammatory M1 macrophage system of responses, which is quite detrimental. So putting some extra pressure onto it is going to further fail the system. Say for example, what we have done. So our patients with heart failure, little bit obese and diabetic. So of late, anyway, these patients were offered insulin, right? They were having good glycemic control. But now for last 6 months, we have started using liraglutide inspired the insulin. What we found, the frequency of the decomposition is reduced. They are more better symptomatically. So this is how you can reprogram the metabolic machinery also. It is altogether not diabetes, it is reprogramming of the central system. If electricity is not there, how am I going to deliver? How are you going to listen? How he is going to, I mean, we can have podium, we can have many chairs, we can, devise them, but what is the central? The electricity, similarly, is the complement activation and the dysregulation of the immune metabolic pathway.
So, sir, addressing the obesity will also somehow, tackle.
Yeah, exactly. Yeah, it is going to take up. Thank you.
I'm Dr. Mrs. Sharma. Sir, nutrition has also started working on it. And that's why in 2003 they have started with chrono nutrition.
Yeah.
So the thing which you talked about is wonderful about the glycogen pathway and cascade. You're right, sir, because we have been treating many patients with the same conditions. But what we realize that when we do the prevention from the start, when you see people start talking about intermittent fasting and all those where there's the glycogen cascade is the one which is developing right now.
Yeah.
And that causes inflammation and ROS. So you're right, sir. I am very glad that you have opened up this thing because when you follow chrononutrition, even the circadian rhythm will change and that causes inflammation again.
Yeah,
and that further leads to a condition. So sir talked about diet and gut. So yes, anti-inflammatory diets have a very, very strong impact on it. And we have seen differences, not in terms of the obesity, but their gut improvement, as well as their GI functions and GI symptoms. So thank you for presenting such a wonderful presentation.
Thank you so very much.
Thank you, sir. That was an excellent presentation, and you advocated a really upstream approach towards management. Thank you very much.